Good morning, everyone.
Good morning.
I hope everyone's feeling as optimistic and energized as I am on the last day of our summit, which is a bittersweet day. I am so honored to have been asked at the 11th hour to be in conversation with two of my colleagues who are next to me. It's a pleasure to be with you both this morning. And they've promised me, since this was an 11th hour agreement, that they will introduce themselves. So the pressure is off. And Andy, since your name begins with A, you get to introduce yourself first.
Well, thank you. So I'm Andy Keller, and sometimes I have a beard, like in my picture, which is up there, but today I don't because I wanted to look more like Tom, just to make us more indistinguishable. And I am a psychologist, and that's what I decided I wanted to be when I grew up, and I'm still trying to get to be that, but I mostly work on policy stuff. So I currently run a mental health policy research organization based in Texas that works with many all in the room. And we're kind of a think tank, but we're trying to be more of a do tank because we're mostly interested in just helping people get the care they need, and that's what we do, and that's what I do.
Thanks. All right, Tom, over to you.
Tom Insel, and let's see, I'm a psychiatrist, but I spent most of my life as a neuroscientist working at a bench in a laboratory at various government and university labs. For 13 years, I ran the National Institute of Mental Health through two administrations, Bush and Obama, then left to move to the tech sector where I worked at Google and then was a co-founder of several companies, MindStrong, Humanest, what else, Neurowell, they're a bunch. And I've been involved with, as an advisor, very much in the digital mental health scene. More recently, I served as a special advisor to Gavin Newsom, our governor in California, where I'm based. And I've written a book, which all of you are going to receive, called Healing: Our Path from Mental Illness to Mental Health, largely about my observations in California, but it includes work around the world. And most recently, I've co-founded with Rob Waters, who's here, a nonprofit. It's doing a digital publication called MindSite News, supported by Sozosei, and which is trying to capture that intersection of mental health and social justice issues every day. And you should have received a copy of that in your tote bag, and there's a wonderful QR code there that allows you to subscribe. It's free. And we're also looking for content. So those of you who have great stories to tell, find Rob, who's here. Find me. We'd love to engage you in the process, which is really all part, as Melissa knows, part of trying to start a social movement for mental health.
Mm-hmm. Thank you, Andy. Thank you, Tom. And I want to underscore the importance of MindSite News to our collective work to decriminalize mental illness. For those of you who are subscribers to the Marshall Project, which is a criminal justice newsletter, I feel that MindSite is to our movement what the Marshall Project has been to criminal justice reform. So it's really important, I think, that we all subscribe and push out and amplify the important work that's happening there. So thank you, Tom, and of course you, Rob, for starting that important innovation. Tom, you're going to kick us off, as I understand it, with some slides to kind of level set. The goal of the conversation today with the three of us is both to kind of dig a little bit deeper into some of our themes and offer some reflections and get us ready for our wonderful event with the Guild of Future Architects.
So thanks, Melissa. It's funny how we got to be a little flexible here. Bringing you in at the last minute was part of that. Originally, I think this was going to be sort of a keynote, and then it was a fireside chat, and then I really wanted to have Andy here, so we've kind of shifted around. But there's still this residual. I had put together some slides, and I'm not going to show you all 20 of them, but I want to share 4 or 5, because I think as we're talking in this session and the rest of the morning about the future, I want to ground this in starting to talk about the past, because I think that's really important for us. Then I'm going to start with this quote, which you can read while I talk to you. This comes, well, I'll let you read it. So several points about this. One is I could imagine in 2021 Dan Gillison from NAMI giving us this quote, but to have a president of the United States say this in 1963 is notable. It's the last time we had that kind of leadership on this particular topic. The second point to make is this comment, the last part that's bolded, that the mentally ill need no longer be alien to our affections or beyond the help of our communities. 1963. So this was the last bill signed by Kennedy before he was assassinated 3 weeks later. It was the result of a campaign, very much like sending people to the moon. This was part of a campaign that started with a joint message to Congress in February of 1963, in which he pledged to do exactly what it says in that last line and laid out the Community Mental Health Act. I say this because I think I'm the oldest person in the room, and I can tell you that when I got into this field in the 1970s, it did not look like it looks today. So we had almost 800 community mental health centers funded by the federal government in a way that today looks like whole person care, comprehensive care. We had a social safety net that was supported by all these new programs that today have gotten a little bit aged but are still active, like SSI and Medicaid. We had less than 300,000 jail cells in the United States. And people with serious mental illness were not in them, or they were not in them at any higher rate than they were outside of jail. And in fact, what is remarkable is that in 1975, there was a deep conversation led by several foundations, including Pew at the time, I think, about whether we should do for jails and prisons what we had just done for the state hospital system, which was to say, close them down. And that was a serious national conversation because, by the way, there weren't that many jail and prison cells at that point in time. And it was thinkable that we could actually move to a very different system for criminal justice. And finally, as all of you know, homelessness was really not part of the national picture. We didn't see it. Now, I tell you this because we're going to talk a lot about, can we imagine a world in which people with mental illness are not incarcerated, where we don't criminalize mental illness? And I need to tell you that that was not thinkable in 1971, right? When I started, it was unimaginable that we would do today what we have now come to accept and what we're trying to think our way out of. So it's critical to understand, as we think about the future, that this used to be us. We could do this. We did it before, and then we lost our way. And what Kennedy was suggesting is we no longer need to have people alien to our affections. We could actually make that happen. Now, the world has, of course, changed remarkably. And this is one piece of it from a figure from the book, in which it becomes clear that as we went from about 600,000 mental health beds in the state asylum system down to 35,000, we moved from about 300,000 jail cells and prison cells up to 2.1 million. Brian Stevenson has said that from 1990 to 2005, we opened a jail or prison every 10 days. There's an interesting way to think about this. You know, we talk about trans-institutionalization, but it does remind us that actually we're capable of creating the infrastructure, in this case, for mass incarceration, but we could have used that to do something really remarkable. So this kind of a figure, which is stunning in some ways, is not irreversible. There are things that can be done. I'll show you one other figure, which I show you with a little trepidation because it runs so counter to the conversation we've been having, but it's important to grasp, I think. And that has to do with this overall injustice. It's not just incarceration. It's on so many levels that people with serious mental illness have not only been neglected, but have been, in some ways, they become the ultimate untouchables, the Dalits in America, not so much in the rest of the world, but in this country. Take a look at these numbers. Now, I want to make a point as you look at this, as we're going over life expectancy, employment, the relative risk of police use of force and incarceration, that as we talked about yesterday, being a person of color puts you at enormous risk for all sorts of bad outcomes. I just need you to understand that being a person with serious mental illness is even worse. And of course, having both, being a person with serious mental illness and a person of color, is double jeopardy, maybe triple jeopardy. But it's important for us to grasp this because this is on our watch, right? And if we have now a very active movement around Black Lives Matter and the importance of looking at things like police use of force, I don't hear people talking about the data or even being aware of the data for people with serious mental illness. And why that is so critical is that this is on us. I mean, for those of you in the room or watching who are in the mental health sector, this is our bad. This has happened on our watch, and it's up to us to fix it. But we can't fix it unless we face it. And facing it is recognizing that on almost every measure you can find, people with serious mental illness are the most neglected and in some ways subject to the greatest injustice in this country. One of those injustices is that nobody even knows this. So I'll just finish up by saying, how did we get here? You know this, so I'm not going to spend a lot of time on it. Obviously, during the Reagan administration, the whole community mental health system, the whole federal support was gutted, everything sent to the states. The war on drugs, which was, honestly, it was a war on people of color, most of all. It was about trying to find a way to incarcerate people rather than treat them. But that was a huge part of this trans-institutionalization. The massive loss of capacity, both in terms of health beds, hospital beds, crisis beds, and then community supports, all of that, which was gutted throughout this last 4 decades. And then we've had this massive shift, partly due to sort of the medicalization of mental health care from the community-focused efforts to what are really, I call them the sick care system, not the healthcare system. So this is also, again, important as a starting point for this conversation we're about to have, because each of these things is changing very rapidly. And I'm particularly, to use Melissa's term, optimistic right now, because I think we're at a real tipping point. On the federal support, you've got 430 CCBHCs, 240 coordinated specialty care programs in 40 states. You've got 988. You've got a whole series of new things coming from the federal government, many billions of dollars, with the additional support promised through infrastructure packages that are one that's done and one that's on its way, that really will rebuild the social safety net. And for the first time since the 1970s, has the federal government taking a role on leadership for programs across 50 states. That's pretty amazing, and it's all happened in the last 3 years. Again, nobody's talking about it, but we need to know that, and we need to realize that this historically is a very special moment. The war on drugs is winding down. The longest war this country's had. It's not over. There's still lots of pockets where this has continued to be a battleground, but you can begin to see what this might look like. And MindSite did a wonderful piece from Michael Pollan when it launched about the end of the war on drugs. What does the drug peace look like? What will that be? We're seeing capacity starting to build. In California, the governor's committed $4.4 billion to youth mental health to build capacity. That's billion, not million. Phenomenal. That's the kind of commitment we've just not seen ever, really, for this series of issues, but it's with the understanding that he knows that we have solutions. They just now need to be funded and implemented, and we need to execute. And I do think, well, it's going to take some time. This meeting and what Sozosei is trying to do is all part of this beginning to shift from the kind of crisis-focused system, the sick care system, to something that looks much more like a mental health care system. So I'm particularly hopeful. I'm going to shut up at this point and bring my colleagues into this conversation, but I wanted to have a start with this kind of grounding that for those of you who think that this is too hard to solve, we used to do much, much better, and we can do that again.
Thanks, Tom.
Okay.
So, Andy,
Melissa?
you want to reflect a bit on what Tom just shared with the group?
Yeah, well, I mean, I appreciate it, because I think it's good to give us a focus to kind of, react to. And, I'm struck by how important it is, two things. One, we got to look back and see how we got here. And also, what did we miss? What opportunities did we miss? And I think if you look at where heart disease statistics were in that same time, we were doing a terrible job. So we had about 500 deaths per million in terms of heart disease at that point.
Right.
And today it's down to 180. So we've made tremendous strides because we don't do things the same way we did back then. We've improved things. And I think the discussion we've had needs, I think those what I think of as narratives of hope. Mm-hmm. I mean, I think it's really important to think of narratives and language and how it constructs our way that we think about things. And I think, Tom, what I really like about how you did that is you kind of wove both together, that there's some hope because we have done these things. It's not rocket science. Mm-hmm. Otherwise, we would have become rocket scientists, but we were doing this. Yeah. And it's also narratives of injustice. And so we need to have both. We need to get motivated and feel like this is wrong. We should be upset about this, but we also need to be hopeful and find the paths forward and make sure that we're addressing both of those things. So that's kind of my overall gut reaction.
Yeah. It's interesting. My thought, Tom, as we prepped for this conversation, one of the things we talk a lot about at Sozosei is that when you're involved in a social movement, sometimes it's very tempting to spend a lot of time on diagnosis and keeping one's eyes in the rearview mirror and how did we get here? And somehow that is to me at least, sometimes a sort of throat clearing, like an intellectual throat clearing. But sometimes we spend too much time there. And I think one of the things we try to do at Sozosei is to move quickly using history as power and as a guide for going forward. So Andy, you bring up, and I think it's a good example, the change in cardiac illness and how that shift happened. So I want to focus in on that for a minute, because what lessons can we learn from that experience that maybe could bring us a little bit further forward with mental illness? Like, why was there so much more investment in that, and how did we move forward, and what were some of the messages that were used, or think pink, or those types of?
Yeah. Well, I think one thing that was different is we didn't otherize people with heart disease. Mm-hmm. So like nobody, when my grandpa had his heart attack, like people tried to resuscitate him, right? And nobody said, well, it's your fault for not eating well or all these other things. There wasn't. And I think the term in President Kennedy's quote about alienization mm-hmm. is a factor that we have, that's unique to us. It's for our medical illnesses. But let's pretend that didn't happen. So, and I think we can. I think increasingly we're moving past that, not fully, but we're working on that. If there's a TV show just to kind of compete for being oldest, Tom. In the 70s called Emergency. Does anybody remember?
I loved Emergency.
Johnny Gage, remember that?
Yeah.
Randolph Mantooth. Anyway, so the pilot for that was this big discussion with people in white lab coats in hospitals talking about, could we possibly take this tremendous technology of resuscitating people and restarting their hearts and put it in an ambulance? Could we do this? Could we take this out and do this? And there's a whole discussion. And I kind of feel like that's where we are. Mm-hmm. Talking about 988. It's like, could we, rather than send police, do the kinds of things we do in hospitals, the kind of things we do in clinics, provide actual care to people. And I kind of feel like we're having that discussion, but that can't be the only thread. Because, and we saw this over the last 18 months with this, what did you call it, the pandemic? What's your term? What's that term? Pandemic?
Yeah, we just learned that
pandemic.
someone, a comedian, not me,
Yeah,
calls it
right.
the pandemic.
Pandemic, yeah, okay.
Yeah.
So I think making fun of things that upset us is helpful. But this pandemic, what did we do to get improved? We're not out of the woods yet, but we learned to detect it quickly. We learned to treat it quickly. We learned to prevent it quickly. So the part about resuscitating, the part about going in a crisis is just one part of this. And so with heart disease, we learned to detect it. We learned to monitor people after that. We learned to give people more effective treatment than what we did back in the day. And Ton, I so appreciated you and your family sharing with us Miles' story at the beginning, because I think that is what we're trying to do, right? We're trying to help your son, we're trying to help my children, we're trying to help everybody's children. And what I was most struck by, I was struck by many things, but that fits in this, was when Miles was diagnosed incorrectly with just ADHD when he was young, a huge opportunity was missed to track. And just like we would with my heart disease risk has been tracked, Melissa, since I was 30. And every year I have to talk to somebody about that, whether it's getting worse. And if we did that for children and youth, when we first detected their mental illness, didn't just put a label, didn't just give them medication, but really thought about this as something we need to do, that's, I think, the most important pathway.
Do you mind if I'm going to push back?
I
'Cause
felt
Andy and I
you wanted to.
we love to
Yeah.
argue about this stuff. And of course, I agree that we figured out how to do this for heart disease, for stroke, for HIV, which used to be fatal, is now it's a chronic disease. My favorite example is actually acute lymphoblastic leukemia, which used to be 90% fatal, is now 90% cured. And that was not because of a breakthrough. There wasn't a new drug. It was just because of much better care. That's what it took. And it took long-term care, which we weren't doing. And it also took the whole nation coming together and creating an infrastructure for that, which was spectacular. All those are great medical examples. But my argument is that this isn't just a medical problem. And we need to think beyond the classic medical examples. So, an example I would use actually is, especially when we talk about suicide and suicide prevention, is traffic fatalities. And I was thinking about this on Monday when Tansy McNulty, who I think is still here, I hope, was talking about, she said, you really want to get change? Get moms involved, right? And we had Mothers Against Drunk Driving, which really had a massive impact on legislation, on creating safer cars, on how we even thought about the problem at the time. I think what this needs, to use your term, is a movement, which we, really is different than the way we address a lot of medical issues, because here it's more than medical, right? There's a social injustice here, which is not going to get fixed through better health care.
So let me ask you this, in reflecting on the last 2 days, if we are building a social movement or engaged in one, what's standing in the way? And I don't mean necessarily internally in the movement, where might we have opportunities to improve? I'll start, since I'm in the conversation, thanks to you both.
Yeah, and it's also your meeting, right?
Yeah, there's so many reasons why I should go first right now. Yes. But I think one of the things that I've been reflecting upon as we talk about data across our work, and at Sozosei, we talk a lot about craving an evidence base for interventions and trying to figure out what works. And there's a spirit at Sozosei very much grounded in curiosity, in a very lively, effervescent curiosity that is about unpacking data, looking at it, wanting to sort of go back into what I think of as the laboratory, to rethink assumptions, and to bring analytical skills and recognize the nuance of data. And sometimes I feel, and at this meeting I've observed, that sometimes we hold out a data point and say, see, it's this. And it stops us somehow. And I'd love to hear your reflections on that how can we do better with either complete lack of data, right, which we know happens, Or when we use data, I almost feel sometimes it's against one another, rather than saying, well, that's so interesting, Tom, that you share that. Tell me more. So I'd love some reflections on how you both feel about how data has come up at the summit, or how we use it in our movement.
Well, first of all, I am so thankful to you and Dr. Carson and Sozosei for putting this together, because like, I go to a lot of conferences, and to be honest, I hate conferences. And when I go to conferences, like, I'm just gonna go for my talk, and I'm not gonna go the rest of the conference. But I've gone to this conference because of who you have here. You've put people together who don't agree. Like, we all don't agree. I promise many of you do not agree with me on many things. And many of y'all don't either. And I think the importance of it, if we're gonna have a movement, is we have to move into some sort of and position on data as opposed to or. So Tom, I think rather than push back on me, you should take my hand and pull me in to the additional data that you were sharing, which is that, of course, these are bigger than medical conditions, and people who are sick at least should have the option of better medical care. I think it's an and type thing, and I think so many things we're doing that, and it's hard, right? Because when injustice permeates something, we don't want to be associated with that. So when we can point out the injustice in like the 911 system, we don't want to be associated with that. But there's parts of that that could be helpful, and I think so there's this tension. So I think that's partially why this is such a hard movement for us, is because we're not aligning around the shared things we're working on.
Yeah, I think that's really true. You know, that there's some great, I'm like super optimistic, so you have to.
Me too. So Andy will keep us pessimists.
Good. No, actually, Andy tends to be kind of glass half full, glass half empty, glass too big, maybe, I don't know.
If there's a single cube of ice in it,
then you're
fine.
okay. Yeah. So data, is data what we need? Yes, but is that what we want to have slow us down? Of course not. I mean, so I'm coming from the tech sector, which is like, that's, data heaven. It's all about algorithms and data, but it's all iterative, right? You act, and you measure, and then you change, and you're constantly learning.
Right.
And it's not a reason not to do stuff. It's a reason to continue to do stuff. We used to joke at Google that, we would be doing 100 experiments on search every hour, and every experiment would have 10 million people in it. And we'd have the data at the end of the day that would let us know exactly how the search box should look, right? Or what the algorithms ought to be. So, yeah, data are, that's critical to being able to improve. The problem with the system we have is that A, we don't measure, and B, we don't learn. So our confidence exceeds our competence very quickly.
Yes.
And that's inevitable when you're not measuring what you do. But the reason I'm kind of optimistic is I look around, and to me, when you ask, like, what does the movement need?
Yeah.
Why isn't there a movement here? I go back to Kennedy. I mean, a large part of what we had then was leadership. And a large part of what we lack now is that. We are all sort of struggling without a kind of coherence, or without leadership, without a clear set of goals, and without a way to get to those goals. Dan Gillison's here at this meeting, and Andy and I and several other people, Rick Keller, some of the people here are all part of something called the CEO Alliance for Mental Health. That's the new name?
Yeah, I think, yeah. I'm not sure we were supposed to reveal that yet.
Yeah, I got permission. I actually got permission. So,
Whew, phew.
you wouldn't have gotten it, but I got it. So.
I
Because
totally.
you had the beard, so
I know, I had the
said
beard, they didn't
you
trust
give it to
me.
the guy without
Texas,
the beard.
the guy in Texas.
Yeah.
Seriously.
So the CEO Alliance is this really interesting project where, so all the years I was in government, when I would work with the advocacy community in mental health, I had to have separate meetings with every group because they couldn't get along. In fact, it was like a circular firing squad. And I'm not going to name them. It was impossible to work with them. Yeah. What the Alliance started doing back in February of 2020, at the very beginning of the pandemic, March, we started meeting every Saturday morning. And it was the heads of all the advocacy groups, the professional groups. I think there were 16 of us at the beginning, 15, something like that. And Dan and Tyler Norris brought us all together. And every Saturday, we'd kind of hammer out, with all the things changing in the pandemic, like what can we do? You know, how do we make sure we're in the stimulus package? How do we make sure that we're focusing on the right things? And ultimately, how do we speak with a unified voice? And we ended up in December putting out a document, it's called the
Unified Vision.
Unified Vision for
mental health and
mental
substance
health.
use disorder.
And it's, you know, it's a really wonderful document, really unprecedented. And now we've put out a statement about crisis services and 988, and you know, we're doing additional things. But so that leadership is there in a way that was lacking before. I don't think we have yet the political leadership from, I mean, I don't hear this topic in campaigns. It started a little bit in the presidential campaign, but didn't make it past the primaries. But I would say that we're on the way. I think at least getting the community of these different groups to around the same table, and we don't always agree, as Andy will tell you, but we find our way to some position we can all live with, and I think that's just incredibly promising right now. So I think data matter, but leadership right now is probably the key. That and sort of a defined set of goals, something that we're all working towards in a way that it's not just fuzzy, but it's a very concrete, measurable, time-bound, and achievable.
I would agree with everything and add 2 observations.
Yeah.
You'll soon, Andy. One observation is that when leadership emerges, I think it is critical for leadership to call out opportunities to improve, and that a unified message is part of leadership in a social movement. But I think part of what happens in the movement to decriminalize mental illness is occasionally, and this might be provocative to some, that there are untested ideas because there's not this heavenly abundance of data as there is in the tech sector. And I love how you frame that. And I see butterflies and unicorns because I am a little bit of a data junkie. And when I can't find it, it makes me feel like I'm working in a landscape of great scarcity. And so I think, and this is sort of to all the funders in the room, that there's a great deal of work to be done to support people on the ground so that they can feel like they have the tools they need to be in this abundant data heaven with unicorns and butterflies.
And cats riding the unicorns.
Thank you for adding that additional image, Andy. It's helpful. That's why you're part of this conversation. But to really give folks the tools they need to collect data, I had a conversation earlier with a very popular intervention that's going national, and had a conversation about evaluating their work, and they told me that they're still using clipboards and papers, and what they really needed were more tools on the ground. And I thought, well, philanthropy, that's a perfect place for philanthropy, is giving folks muscles and tools to be in the abundant heaven of data heaven. I'm not quite sure how we're spinning that. So that's kind of one thing, is to really use leadership to call out opportunities to get even better. And then I think a little bit, because there's so much happening globally, COVID certainly we talk about, but something we don't talk a lot about, I think, in these meetings is and I was sort of joking, not joking about it yesterday, is the erosion of sort of central tenets of democracy, as well as kind of a cultural incompetence around being able to have healthy discourse. In addition to which, the loss of reproductive health care for women in this nation. And I think that that's a social movement that grew up in a certain way that has failed, and that there's a lot for us to learn there. So those are just some thoughts from the seat of a funder that I wanted to bring into the conversation. I think, Andy, you might want to say something.
Well, no, I mean, I think that's really powerful. And I think so a movement I think about that we need to learn some lessons from alongside that in that way, and I think data are a big part, which I'll want to mention in a sec, but is the education reform movement. So like, One of my mentors was, started working on that in the 80s, saying, we need more accountability, and this was in Texas, and, in Texas, we were really bad. We were much, much worse even than we are now back in the 80s. And so this accountability frame that came out was helpful, but the problem was that, and this is what he said, because it took us about a year to convince people that there was something wrong with K-12 education. And we've been spending the rest of our time since then trying to convince people that we could actually do something right. And I think we're somewhat in that dilemma in our field, because I think we all know that there's many things wrong. And we often will go to leaders and try to tell them the story of what's wrong and hope that that will inspire them to come up with something right. And we have to give them tools about what's right. And the problem, to me, with some of the data is we just lack we use data so poorly. So, one of the things that we've talked a lot about over the last couple days, and many of us are talking about, is the data on alternative response in the community. And so we'll talk about Cahoots. So we'll talk about Be Heard in New York that are, no police responders, non-police response. And we'll talk about, let's see how few people go to jail. Well, that's because that's a subset of calls. Be Heard only gets 24% of the calls because the other 76 are deemed dangerous or risky and they don't go there. Cahoots rules out anything. So when you're talking about the tremendous success rate of how no one from Cahoots needs police, it's like going to a private school and saying, look how many of them got into college. 99% of these people in the private school got into college. Well, yeah, because nobody was allowed in who wasn't going to go to college. So that doesn't mean that Cahoots is bad. It means Cahoots is awesome. But we also need to provide something to somebody who might have a knife, or somebody who might be feared to have a knife because of prejudice against that individual that causes an individual who doesn't know them and sees them in their backyard to be scared. So I think we have to weave this together as opposed to saying this or this. We say, no, it's this and this, and it's basic data. It's like include the denominator in addition to the numerator. And we don't do that because we haven't come together to work together effectively.
Yeah, Andy, I think that's a great point. I mean, this issue of when you talk about what do you collect, what do you measure, creating some standards. It's one of the things we try to do at NIH and have still work on are data standards, getting what we call common data elements. And what that means is that you look at Cahoots and you ask them to collect the same data in the same way so that you can compare and understand this. Yeah, does the name Hans Rosling mean anything to you? Have you ever heard that name, Hans Rosling?
Yeah, there's a guy in the best Christmas movie ever, the one with Bruce Willis.
No. Oh. Good. It's close. Okay. He was from 2005 to like 2010, 2011. He was #1 on the TED Talk circuit. Like of all the TED Talks online, his was the most watched TED Talk. He was a Swedish doc, an epidemiologist who developed something called Gapminder about data, how to show data. And he would come to meetings like this, and he would do this really cool thing. He would give the audience a multiple choice test. And what he would put up was sort of data questions. He would say, he was interested in global health, right? So the questions would be like, rates of maternal mortality, the number of girls who finish 6th grade, the vaccination rates. And he'd give you a multiple choice for around the world. And people did terribly. Just terribly, like less than 50% correct. But the interesting thing, and this is what his talks were about, was that they always thought the conditions were much worse than they were. They couldn't see progress we had made. They couldn't understand that maternal mortality had dropped by something like 60%, or that 90% of kids around the world were getting vaccinated, or that we had tripled the number of girls getting through 6th grade in the developing world. And his point was that we're all watching the news every day, right? And we're all seeing the tragedies, we're all seeing the failures. And because we're not seeing our successes, we've stopped realizing that we can succeed, that we can do this stuff. And we've done it, and we're doing it. And yet we're not aware of it. So one of the things I would say about data, to channel Hans, is that it's important to actually show success. And to be able to demonstrate what's working, and to help people to understand we can do this. What it takes is commitment, leadership, execution, sometimes money, although in California, we've got this commitment of money. It's not a
Right.
money issue anymore. It's really, it's figuring out now the what and the how.
Yep. No, I appreciate that, Tom. And, as a fellow optimist in the conversation, I can meet you there with and, now that Andy is telling us to say
The first three
and.
letters of my name.
I was going to make that joke. Thank you for doing it for me. But I think you're right. And I think also some of it is we live in times where we are so inundated with short little pieces of information all day long. And it is a somewhat punishing environment to be creative and curious in, because it's like data overload, information overload. And so another thing that I'm thinking a lot about and reflecting on our time together, I, like you, Andy, hate conferences and try to design this summit with that hatred in my heart so that we have a different experience together.
Yeah.
Because who needs to go to another one of those meetings? So when we send you our survey after this summit, bring that hatred in your heart of other meetings and maybe even this one, because that's how we make this meeting better. Because part of what I want to make more time for is a nuanced, patient discussion about all of these opportunities, and so we can blend optimism and pessimism and all the ingredients of data and really have some honest conversations, because I think we are on the precipice of this great, again, I share it, this really positive, different world, and we're going to be doing some of this imagining with the Guild of Future Architects. And I want us to have the patience with one another to get there, and the fun and curiosity to build that future together. I want to ask, sort of insert one other thing into our conversation and then welcome everyone virtually and in person to join us in conversation using the mics if you're here and pressing submit if you're virtual. But Tom, you started talking about technology, and I hope the two of you don't mind a conversation that we keep saying we're going to have together, but we've had individually. So now we're going to have it together with an audience, which is this. We've talked a little bit about some of the new tech developments with mental health care and apps and telemedicine, et cetera. And we've rooted to a place that those are great developments, but they may not be reaching people with mental illness who we are all particularly concerned about and are working towards when we're working towards decriminalization. So I'd love some reflections on the promise of technology, what we're missing, and maybe some pathways forward that we could really harness this power of tech to decriminalize mental illness.
Yeah, you bet. We should do this together, because I know we've talked about it. Yeah. So I guess there are two answers I have to that.
Yeah.
One is yes, right? So technology is transforming much of mental health care. I look at a company like Cerebral. Did not exist 2 years ago. Arguably, it's the largest mental health care provider in the United States today.
Right.
Valued at $4.8 billion, 6,000 providers, over 200,000 people in care. I mean, and by the way, the founder's 27, 28 years old, 29, it's just phenomenal. So there's big changes. I'm not saying that that's the answer, but we're in a moment, talk about a tipping point. The last couple of years have been transformational for how mental health care is accessed by many people. I use the word access because that's the problem they've solved. They haven't solved the problem for quality. They haven't shown outcomes, lots of issues. But let's face it, this is the very beginning. This is chapter 1. This is a 5-chapter, 10-chapter book. We've got a lot more to write here. But there's no question that the tools that come out of the tech industry will fundamentally transform this area of care more than any other in medicine. So this is going to, with or without us, because we're kind of like the shopping mall, they're like Amazon. So like by 2030, 2035, we're in a different world, and most of us are going to be, the shopping mall still, unless we change. So that's like one answer, yes.
Yeah.
And my heartburn there is that we'll end up with about $4 or $5 billion invested this year, 2.4 billion last year. It's doubled every year, and it's continuing. So it's enormous amounts of capital going into this space. Hundreds of companies forming, lots of very talented people getting engaged. They're not talking about the things that we talk about.
Right.
They're not in this area. So and this is where I think philanthropy can help us to catalyze this moment in time when there's so much capital going in, but it's not going to the right problems, or not going to these problems.
Right.
It's odd because there is a lot of investment in emergency services for medicine, for primary care, Ready Responder, Rapid SOS. I mean, there are all these companies that are now huge that, again, started less than 2 years ago. But in the mental health space, it's not happening. And we've got to figure that out. We've got to figure out, again, what are the tools that are really going to transform crisis services, follow-up from hospital, kind of consistency of care, all that stuff. That's one answer. So very quickly, the second thing I wanted to say, though, which I think is important to grasp, is that when we talk about the tech sector and mental health, it's not just about the products and the tools. I want us to think about what the tech sector does so well that we're doing so badly. And there are three things there, very quickly. One is they know how to solve for engagement. What we were talking about, consumer-centered design and all that, everything in the tech sector is built. You don't talk about a product until you meet with the users. We should call them consumers, but that's where you begin. And every team has got a huge design element to it that's all about understanding end users and what they want, and you build for that. You don't build for the engineers. The second thing is it's all about scale. They know how to scale. And the third thing is they know how to learn, as we were talking about before. It's all about what you do today is different than what you did yesterday because you have the data from yesterday and you know how to iterate. You know how to use that data to get better and better every day. So it's a very different model. And those three things, engagement, scaling, and learning, are really what the tech sector can bring to this. It's cultural.
Yes.
It's not just the apps and the products. And we need to engage them for that purpose as well. Andy, I'm sorry.
Oh, I think that's a beautiful framework. The only thing I would add is I think there's a tech divide that goes way back with our illnesses. And I think it begins with that alienation frame. It's like, where did they build the psychiatric hospitals? As far away from communities as possible. We're working with a health system, want to build a hospital. They're building a new psychiatric hospital. They said, well, let's move it 2 miles away from the main hospital because we'll have so much more room there. And so we showed them the data, said, well, by the way, these people have below the neck issues too. It's just not above the neck. So we showed that folks have lots of needs, and those data allowed them to actually, now we're building the tower together so we can actually treat both. So we have to take that tech and drag it into our community and make it available for our people and quit having our health services be put in some other place. And I'll tell you too, it's not just the fancy stuff. Like I endured a test, which I shall not describe, because I'm over 50 last week, and I have to get them every 3 years because I got these stupid benign polyps. And it took a lot of time, and I did not want to do it. And they spent a lot of money on this. I had 4 professionals. I got to ride around a gurney. I got some really good drugs. I woke up later. And I had 2 really bad days before just drinking gross stuff. And just to try to not die from colon cancer. And it's about the same number of people we lose to colorectal cancer every year that we do to suicide, around 50,000 people. And so they did that to me to try to not have me die from cancer. But we will not give people a PHQ-9, which takes 5 minutes and is easy, and by the way, is 90% thing. And the problem is there's no money in that, right? It's free. So nobody's gonna make any money from y'all giving the PHQ-9 to everybody. And we gotta get past that. And part of that's will, part of that, but I think part of that is channeling our inner anger and our inner hatred to say, we deserve these things for our folks. So it's the divide we have to get past.
I really appreciate that, and appreciate your colonoscopy story, and everyone over 45 should be doing that. Just a shout out for some preventative health care. I want to open it to the audience, and I want to say something else because I thought you were about to go into healthcare policy and broken payer value, fee for service. And I want to say that that is a conversation that is so stale in this country and so boring. And I would like to ask all of the artists in the room and doers and makers and thinkers and playwrights, and I have an ongoing joke with Dan Gorenstein, who I think is here from Trade-Offs, that we're going to write a musical about healthcare policy. We started last night, Policy Schmolicy, as the opening number. But all joking aside, I think we also need to find different ways to communicate about these efforts, and that's another role for philanthropy. That being said, I'm going to start on the right with our first question.
Hi, Dr. Insel. Thank you for reminding us about the profound suffering of people with severe mental illness, this forgotten population. I spoke yesterday about bringing together ACT teams with Housing First, and how this is an example of how people with severe mental illness don't get a diagnosis of doom, and that it's possible for people to thrive and flourish. And I also shared that these services pay for themselves, right? Even just saving healthcare costs, and if you add into that criminal justice utilization, then you can extend this to other populations. And so the question I have is, I agree we can build this infrastructure at scale. So how can we do this urgently when the unit economics are already there in our favor?
Yeah, so I guess it forces the question, or begs the question, of why aren't we doing it already? And I don't want to go into the financing piece, because Melissa just told us that it's policy schmolicy or something
So
like that.
you can be a co-writer.
Yeah, I'll join. Only if I can get some of the royalties from that very successful
talk.
musical.
Yeah.
I don't know that I have exactly the answer for how one does this to get it going, but I think one of the ways you start is by helping to make the economic argument, which has not been made successfully enough to the people who ultimately have to pay. So I learned this when we were working on technology for mental illness, when we were trying to sell this to payers. They said, like, we only spend 4% of our budget on mental health. We actually don't care about this. But if you can have an impact on diabetes and heart disease, then we got something to talk about. And we had to show them that by getting better mental health care in their patients who were comorbid, we did indeed save them money on the medical side. And then they were excited and interested. So I think we have to frame the right, here's the problem. If this is a healthcare conversation, it's a business conversation in America. Not in any other country, but in this country, it's a business. And so figuring out the economics is unfortunately the first order of business. And we have to do that for ACT teams, which, by the way, the data are spectacular for. Only 3%, or no, 2.1%, according to ISMIC, of Americans with serious mental illness have access to an ACT team. 2.1%. Imagine that for any other medical problem with something that is as effective. Unbelievable.
And we've known ACT teams work only since 1972.
Only since 1972.
It's only been since 1972.
In Wisconsin.
Yeah, exactly. But here's the thing. So you said this 4% of healthcare spending on mental health. Before managed care in the 90s, it was 7%. So one of the worst things that happened to us was the behavioral health carve-out, which took basically the cost for this and put it in a cost center that we managed the hell out of and got to be as low as possible, but it divorced it from the below the neck things. Because if I have a heart attack and I'm depressed, I'm 3 more times likely to die after that heart attack because I'm not getting care for depression. So we have to bring the whole person finances and whole society, like the whole person, not just the medical, the rest of their lives as well. But I think the economics are a huge reason for that.
Thank you both. I'd like to go to the left side, but I see one of our courageous production people there. All right, here we go, left side.
How you doing? First of all, I'll just say thank you for this conversation. Douglas Reed, Director of Partnerships from Black Men Heal, removing the stigma around mental health, culture, competency, and providing free therapy to Black men. But as I mentioned earlier, I was a client and actually became a mental health advocate. But my passion is around decriminalizing mental illness. One, because I retired out of the Federal Bureau of Prisons after 25 years and seeing the lived experiences of men and women that came into during the 1986 crack law when I started in 1992 with the rise of institutions being built around the country. So I'm just here to make a statement to because my passion comes from, after I retired, trying to make a difference within our community to stop this wave from going on. So I kind of offer myself and kind of taking this moment for anybody that's here on how Black Men Heal can make a difference in this particular arena around decriminalizing mental health, especially in regards to individuals, men and women, going to prison. So I just wanted to make that statement and say thank you, and we're always available. This is a passion, and it's kind of tough for me not to get really excited, but I'll just say I'm available. So anybody need my information, I'm here. So thank you.
Thank you.
Thanks, Doug.
Thank you.
Bravo. Yeah. I'm so glad that you're here, and I really appreciate your statement and sharing your work. Over to the right, and I'll get to a virtual in a moment.
Hi, thanks. I have a quick comment and a question. I'm Moki Macias. I'm Executive Director for PAD in Atlanta. And we've been diverting people from arrest and incarceration who are experiencing mental health concerns for the last 5 years. And just recently this year, we launched a partnership with our City of Atlanta non-emergency line, our 311 line, in order to accept community referrals to avoid police involvement altogether. And what I've found in most conversations related to decriminalizing our response to people experiencing mental health concerns is that we tend to focus on the most serious emergencies, right? And that is actually what 988 is intended for, right? And it sort of, in that way, has really continued to sort of draw the attention to the most serious emergencies. But what we know in practice is that it is actually the very low-level charges that drive people experiencing mental health concerns into our jails. It is the criminal trespass, it is public indecency, it's disorderly conduct. And we're not designing for what we actually know is is driving people into our local jails. And Melissa, if I could, in the spirit of creative disruption, I'd actually like to direct my question to one of the very important and powerful leaders we have in this space, who's not on the stage, but to Karis, if I may. Is that all right?
Of course,
Okay.
if
Can
it's
I
okay
take
with
the mic?
Karis.
Can I take it? Okay, thank you. So my question, is how do we leverage the momentum of 988 and all of the resources that are now coming into addressing mental health concerns to actually get to this issue of people getting pushed into our system for the kinds of things that they're doing simply to survive?
Okay, wow, that was a little embarrassing, but okay. I'm so glad I love you, Moki. So first, I'm going to start here is that, and this is probably going to be very difficult for me to say and may generate some tears. It's very hard for me to see a slide that says SMI and Black people separate, and to take the BLM movement and say we're not talking about SMI. I will argue that, in fact, the BLM movement started the conversation about defunding the police because of the overwhelming deaths that we have had, not deaths, murders at the hands of law enforcement. And in fact, many of those people are people who, quote unquote, were in serious mental health crisis. So to separate it out does not help our conversation. And as a matter of fact, when that BLM kind of kicked off, the mental health movement jumped in on top of BLM and did not talk about Black people. And it became a conversation only about, quote unquote, serious mental illness, leaving out the disparities that happen with people of color. So I think if we're going to talk about that kind of framing, we need to put the, thank you, Andy, for both and. I am the queen of both and. But that we have to recognize that, in fact, there was a movement after BLM in the mental health space around looking at alternatives to using police and force. I think that has to be said. Otherwise, we're starting in a space that isn't authentic at all to our experiences. And that hurts. It really, really hurts. So I'm sorry I had to start there, but I didn't think it was fair not to say something about that, because too often we're silent about it, and we just can't do that. I can't anyway.
Karis, can I respond? You and I have had this conversation separately, so I think it's important to share this, because You're absolutely right. And one of the issues, as you look at that literature, is that that question isn't even being posed, right? So the people are collecting data on whether it's, early mortality or police use of force, and they're not breaking the data out by racial, ethnic detail. And so you can't even, there's no question, I think all of us in this space understand that double jeopardy problem, and yet we can't get good numbers on that. This goes back to your data.
Well, that's what
your
I
data
was
point.
just thinking, is that part of these important conversations, and I'm so sorry to say this, but as the gatekeeper, I have a red light at time, and so I want to say this, that a lot of these conversations go back to, as within social movements, all social movements, I think, and community work and the urgency of care, is that communities are forced to work in environments of great scarcity. And that part of what we're going to be doing with the Guild of Future Architects is to try to imagine what it would be like to be in a world of great abundance, so that we could have the data we need, so that we could have conversations to push back, and really have the tools at our disposal to make the best possible decisions in social change. Karis, I know that you have the mic, and I really want to honor and respect that, but I also have to honor and respect the time, particularly because it's our last day. Now, we do have a lot of time together today in community. I want to welcome the Guild of Future Architects onto the stage because they're going to segue us now that it's time. Using Tom and Andy as the segue, I am inoculated from that because I'm the executive director. And then we'll be doing some work here. And then we're going to go upstairs where we'll be in community at tables. And then, sadly, we will end our time together, except that if you are a staff person or on a board of a foundation, we are having a lunch to do sort of a philanthropy debrief at the end. So, Guild, would you like to come up? And
I don't know if these, they do. These are our backup mics. My name is Robert Sinclair. I am one of the members of the Guild of Future Architects. I'm one of the founding members of the Futurist Writers Room, an offering we've done for the Rockefeller Foundation, Doris Duke, Google Creative Lab, dozens of others, and for all of you today, so we're very excited about this. I didn't know we would have the comedic stylings of Melissa, Tom, and Andy to sort of lead us into our, I didn't know you were funny, so it's pretty great. And the quotable I took so far today was, design a conference with the hatred in your heart. That's how you really make it work. I like to steal quotes and then quote all of you in other writers' rooms, which is really fun. So we're going to do a transition by asking a question. We are futurists. We try to reframe these issues and these questions in terms of story, because as Tom, I believe, or Andy, together, they're a team, stated, you need to really get beyond data to move the public conversation, right? And so the idea of this conference is about decriminalizing mental illness, right? What does that future look and feel like? What is the story we're telling people and ourselves about? What is it to be in that future, not just in the soup of trying to create it? And if you don't have that story and that framing and that imagination, it becomes a very obtuse idea to people. I mean, a gentleman upstairs that works for, was just putting out the food, was like, well, what is this even about? What is, for me, how would I understand any of this? And he's been listening to conversation for the past 2 days. So, that being said, Andy, you mentioned a few things about mental health in Camelot in 1971. You talked about how there was an inflection point where we could have actually maybe decriminalized mental illness in the 70s, right? Before it even, before it even got started. I was looking at both of you. Here's a question, just a quick question. What would our present moment look like if mental illness had never been criminalized in the first place, right? What would you be doing?
Yeah, so maybe I'll do a quick, we'll both answer this. The good news is it would look kind of like diabetes, heart disease, other brain disorders like, Parkinson's. The bad news is it would look like all those other medical problems. I think we could do better than that. But if we had I mean, I can't think of another medical illness that is criminalized except for addiction in the same way that mental illness is. So if you take criminalization out of it, you're left with a medical illness like any other, with all of the problems we have, which is that we have a healthcare system that is way too expensive, really inefficient, based on crisis, doesn't work all that well for a lot of people, but at least we'd be there. I think that's the way I would see it if it weren't criminalized. Andy?
Yeah. Well, and I think actually the way I frame it is around, to quote Dr. Carson, you use a lot, which is if you're getting your first diagnosis in the justice system, in order to not be incarcerated, you're going to have to get your first diagnosis somewhere else. And I totally agree with Tom. The diagnoses are not the goal, right? Getting help is the goal. But these are pediatric illnesses. So like my anxiety disorder, there's ample evidence in my baby book about my anxiety disorder. And also more severe mental illnesses look a lot like anxiety disorders when you're a child. And so we would be talking to parents and families and children about their emotional well-being, and we wouldn't be doing it in a pathologizing, diagnosing sort of way. And we'd be helping families build the emotional wellness of their children and also monitor emotional wellness, because it's not just the family, it's what's inside your body could click in at age 12 or age 18 or age 25 and take you in a different direction. So we have to be with you and help you find your need before it becomes evident to the community. And I think that's what we would be doing. We'd be helping people find their needs before they even know that they need the help.
I like that.
And then a follow-up to that question. How would a child's life be different if a child today suffering from anxiety disorders that lead to mental illness, how would that child's life be different as an adult in 2021 now, as opposed, in our speculative world where it was never criminalized and where people have an understanding of mental first aid and there's parity between above the neck and below the neck? What are some of the benefits? Like, how would that child's life be improved in quality of life?
Well, I want to actually talk about something Kara said when she was sharing her story the day before yesterday, which was when you were talking about an anxiety disorder, obsessive compulsive disorder, people still talk to you about getting a job, living your life, going to college, having a family, everything else. And I think that's what we would do. We would not treat a diagnosis of schizophrenia or a diagnosis of psychosis or a diagnosis of severe depression, I'm going to die from suicide potentially, as some life-altering event. Like, you can live your life. We can do all these other things. I think that's what we would do. We would live our lives managing our emotional wellness. And I think that's how it would look different.
Yeah, I guess I would say the same thing in a way. I mean, I think we're in this imagined future where we'd like to be is to move from a medical system that's largely about diagnosis and treatment to a recovery model, which is really about what I call the 3 Ps: people, place, and purpose. And that for every kid growing up with any sort of above the neck issue, the focus would be on people, place, and purpose, making sure that they had the supports for each of those 3 Ps. Because we know that's what you need for recovery. We know that's what you need to thrive. It's not part of healthcare, but it is part of having a life. And that ought to be where the focus would be. Mm-hmm. That's why I say, if we limit ourselves to saying we want to be just like a medical problem, we'll not get any further than that. And that's not great for us. We have to be able to be a little more ambitious and to think beyond this what I think is a narrow medical model, which is, by the way, what I used to always fight for, only that. I think we can do better.
I appreciate that reflection, Tom, on your challenging your assumption about what you used to do and now you do. I now get to thank you both for talking to me. Thank you. And I turn it over to the Guild, and thank you.